several books where we had the privilege of helping out. He also holds several patents and is a founder of two medical device companies. He believes the new order will consist of intelligent robot working alongside cyber-enabled humans and use of artificial intelligence in all fields of life, including medicine. He's married to Dr. Gordana Jurek. She is a neuropathologist and they have three children. His current research products include AI for prediction of outcomes in subarachnoid patients and guidance in their management, internal jugular vein massage device for prevention of elevated ICP with improving CSF and lymphatic flow in patients, and one more disease, this one which is really sincerely working on in a big way, is mini hospital in the space and moon stations. If it works out, it's something will be, I think, something out of the world. And one more on personal note, I was a fellow with him about almost a quarter century back, 25 years ago. Now my daughter is doing her PhD in medical robotics on the engineering side, where he's also a course supervisor. So over to the chairpersons to initiate. So I call upon Dr. Suresh Bapu to initiate. Can we have the chairpersons please here?
So Dr. Raghundan will be talking on decision making in cerebral AVM.
Good evening, everyone. Most respected Professor Laligam Shekhar, my teacher, Professor KRS Bisar, and senior consultants, colleagues and friends, and actually, at the outset, I should thank the organizers for giving me this opportunity. And as we all know, AVMs is direct connections between the feeding artery and the draining vein with the nidus and no capillary in between. And this concept of pile recruitment or perinidal capillary network is very important because it's the indirect supply to the peripheral part of the brain AVM and is the main reason for recurrence. If that is not taken care of, it is not treated, it's not excised, then it is the cause of recurrence. And as we all know, this is the risk factor for rupture. There is a prior hemorrhage. The overall is 3, unruptured AVM is 2.2 and unruptured is 4.5. And a deep location, prior hemorrhage, exclusive deep venous drainage and an associated aneurysm has a higher risk rate of rupture. So a symptomatic AVM has a high rupture rate within the first 5 years. When there is a previous bleeding, it increases by 44%, normalizes at 5 years, and rebleed rate is higher in a large AVM, whereas the first bleed possibility is higher in a small AVM. Small, deep, exclusive deep venous drainage, posterior fossa location, associated aneurysm, varix, they are all risk for higher bleed. So the simple risk calculation is 100 and minus 5 minus age of the patient. We have a lot of calculations. And the three main risk factors for rupture are previous rupture, deep venous drainage, deep location. And when you have three risk factors, the risk increases by 30% annually. So if you look at it, the AVM rupture rate can be as low as 0.9% and as high as 34%. And recently after the Aruba, there has been a big hue and cry about the conservative management that should be offered for the AVM patients and also the brain AVM bleeding may be less than previously thought about. I'm not going into the flaws of the Aruba, that is beyond the scope of this topic. But one thing, the spectrum of, we have to look at this spectrum about the interventional harm. See, most of these patients microsurgery was offered to only 5 of these patients, whereas embolization standalone was given in 30, SRS alone in 31, and as a combination. But when you consider that 68% of these patients in the treatment group had grade 1 and 2 AVMs, and for which microsurgical excision is the gold standard, but it was not offered to them. On the other hand, most of them underwent embolization alone, SRS alone, or a combined embolization with radiotherapy. So this distribution among the intervention arm was, with the Spetzler-Martin grading of included AVMs, deviates significantly from the standard practice or the treatment of low-grade AVMs, particularly when it is 68% is grade 1 and 2. And this predictably led to the suboptimal outcomes in the intervention arm, which led to the later concept that AVMs can be conservatively managed. At the same time, post this Aruba, there have been a lot of retrospective studies and meta-analysis that has been done. And most of them restricted to single main form of intervention to detect if there is any treatment-specific outcomes. And this is one of the large meta-analysis which we will see in the next slide. The annual rate was almost 4 times higher in lesions that had previous bleed compared to a unruptured AVM. Ruptured lesions are usually treated as per the meta-analysis to mitigate the risks of rebleeding. And at the same time, we'll never have a robust data on natural history and treatment risk with all the biases of all studies. This is a very important slide. This is a meta-analysis of various intervention arms. So this is Aruba, obviously. And this is the patient's list which you can see, and the numbers in the bracket indicates the percentage of low-grade AVMs among these whole numbers. And this is microsurgery alone, and this is radiosurgery alone, and this is endovascular embolization. And this is the intervention which was given and the design, and that is the mean follow-up and the stroke death rate. We all know what Aruba had done. But if you look at that down, the highest mortality rate comes here is 19.7, and that is a study with a standalone embolization. And we'll see that 51% of this standalone embolization, embolization was low-grade AVM. So, and if you look at the other factors, 16% here, that alone is MS plus EE, 46% and GKRS. And if you consider radiosurgery here, what you will find is, as the follow-up period increased, you will see that the stroke and the death rate also increased considerably over a period of time. As long as the follow-up period progressed higher, it led to an increased stroke or death rate, which was the primary endpoint of the Aruba study. And this, when you consider the microsurgery alone, it was 7.7%. So this is a very important slide, an eye-opener. And this analysis demonstrated similar stroke incidence for the first 5 years of follow-up, after which the cumulative stroke incidence became higher in the medical Aruba cohort. And the cumulative incidence kept increasing as the follow-up time progressed beyond 5 years. When it was stratified along with the AVM size, longer follow-up time may be needed, more than 11 years, for large AVMs of more than 2 demonstrate less morbidity and mortality on treatment compared with observation. And these findings were similar to those of the Polak et al., where radiosurgery patients with larger AVMs had a higher risk of stroke or death over a median follow-up by 5.3 years. At the same time, the risk of adverse neurological outcome for radiosurgery patients, symptomatic radiation changes or post-radiosurgery hemorrhage, permanent neurological morbidity or death, was an average follow-up of 7.2 years was 13%, which is very high. On the other hand, Aruba gave standalone endovascular embolization for 26% of patients, and we already saw the singular study, of which 41 and with Onyx and 57 with Onyx and Linac. And during a median follow-up of 5 years, 20% suffered from stroke or death, and treatment-related mortality reached 7%. And all of this despite a selection bias towards the favorable profiles for both endovascular and the stereotactic treatment. Related morbidity in embolization focus approach was high, which may partly explain the elevated rate of adverse outcomes in the Aruba. And this is embolization, and artifacts after embolization can obscure the target, and recanalization of embolized volumes that is not targeted by SRS and embolic material deposited when it is patchy and if the embolized AVM is larger. So a recent review of all the literature regarding use of endovascular embolization with intent to cure of both ruptured and unruptured confirmed previous notions of increased complication rates. And Chapo et al. Echo the same concern also, highlighting the absence of robust data. Given today's existing reports, modern use of endovascular embolization remains as an adjunct to microsurgery with the main goals of decreasing intraoperative blood loss in large AVMs, securing associated aneurysms or deep arterial feeders, particularly when they have a fistulous connection. So endovascular treatment may seem more attractive to patients, but its use as a primary or combined therapy for low-grade AVMs is not supported by the current data. Deep feeders, yes, it can be taken care of, particularly when they have fistulous connections. And if it is used as an adjunct to SRS, the dose should be limited, because higher the dose of the embolic material, the lesser is the efficacy of the stereotactic radiosurgery when it is done later. Microsurgical resection remains an indicated and effective therapeutic intervention of unruptured AVMs. So natural history of data that was provided in Aruba, we should look at that as what is the most important point. They said 10% of patients will have a risk will develop stroke or death, and 15% risk of disability over 33 months. Which in other words means at the end of 99 months or 8 years later, you would have lost 10% of your patients to major stroke or death, and almost half of your patients to disability. Half of your patients will be disabled. That for a physician is unacceptable. That is what I would say. So today the current management paradigm, while Aruba had numerous limitations, we are not going into that. Microsurgery remains a highly effective avenue for managing AVMs, especially if they are low grade, has been regarded as the gold standard of AVM treatment given its favorable cure rates, safety profiles, and immediacy. The key to achieving good outcomes is appropriate patient selection in high volume multidisciplinary centers. Embolization does have a role in deep feeders, particularly associated aneurysms and especially with fistulous connections, and radiosurgery would play a more important role in deep inaccessible lesions or those having an intimate association with enlargement cortex. So management today, there is a pooled analysis. The grade 1 and 2 have been pooled into group A and can be managed with microsurgical resection alone, achieving good outcomes of 96 and 90. And the class B, which is a grade 3 AVMs, which has a heterogeneous collection, and based on the angio architecture, a specific therapy has to be taken. A conservative approach may be warranted in patients with these AVMs when they present without a history of rupture. And for high-grade AVMs, the class C, the group grade 4 and 5, conservative management is the recommendation unless they have progressive neurological deficits or they have repetitive hemorrhages. So looking into my personal series in the past 5 years, I've done 21 across various grades, and results are no mortality, seizure, new onset seizure in 3 patients. 2 had developed worsening of hemiparesis. Visual deficits persisted in some patients. 3 patients with hemiparesis actually improved. So among the grade 1, these are all some of the AVMs. This is a cerebellar AVM which we have done, and this is frontal interhemispheric. And among the grade 2, this was a young boy who underwent this surgery, and this was another AVM which he done. And this was a medical student, an ICA supplied from the feeder from the ICA, which he underwent a total excision, that is the postoperative CT. This is another grade 2 AVM, that is the post-op CT. This is a grade 3 AVM which we did all in the Institute of Neurosurgery in the past 5 years. And during COVID, yes, we had a small dip in the number of cases. This is another grade 3 AVM which underwent drugs, and this is the patient. She came to us with a lot of field defects in the visual, but which improved subsequently. This is another grade 3 AVM. This is another one which we have excised. We did have the opportunity when the angio architecture we thought is good. We did operate on some grade 4 and grade 5 AVMs like this. This is another grade 4 AVM. This was a patient very close to the motor cortex, a young fellow who got recently married, developed a recurrent hemorrhage and a hemiparesis, and this is the patient. This is another AVM. And grade 5, yes, we have done 2 AVMs. This was one of the grade 5s. And yes, it was tough to do that, but yes, we could achieve a total excision. This is another grade 5 AVM patient came to us with a hemiplegia, with an altered sensorium, a huge AVM, both deep and feeders. And we went ahead and did a total excision. And this is actually the patient. Actually, this was his 4th post-operative day. His weakness occurred, and we had a fire accident in the neuro block, and he was evacuated as an emergency during the fire accident. So to come finally, endovascular procedures, yes, it can be used as an adjunct in surgery to minimize blood loss, securing associated aneurysms, reduce rebleed after stereotactic radiosurgery, and in fact very useful in radio-resistant direct fistulous communications. And SRS, yes, the AVM score is 1 or lower, good obliteration is achieved, but if the score is more than 2, only 39% achieve the optimal. So surgical resection, yes, it is a definitive cure with no waiting period. Operative risk, yes, we have to take the chance to give cure, varies with the Spetzler-Martin grading. The risk of bleed is never 0. Even after angiographically proved obliteration, the estimated annual risk is 0.3%. So the wisdom is, if you don't do anything as Aruba has told, based on the natural history of the disease, 10% death, disability 15% in 33 months, that is absolutely unacceptable. Non-microsurgical means, yes, they have close to 20% when you take the disability, death and stroke rate is concerned. So we have to select the cases once we go beyond the grade 3, 4 and 5. Selection, age, there is a progressive deficit, if there is a bleed, based on the angio architecture. If you have a surface vessel, whether it is a vein or an artery, then yes, you can trace it. Embolization and SRS, I do not use personally before my surgery because of the fear of leaving behind the perineidal capillary network. And the take-home message is conservative is 10, radio and endovascular is 20. Across group A, microsurgical excision, it is 3.5 and group B is 7.7. Group C is mostly palliative. If there is recurrent bleed, progressive deficits, you have the experience, select cases and intervene. And I take this opportunity to invite all of you for the Professor S. Kalyan Raman oration to be delivered by Professor Laligam Shekhar this coming Saturday at MMC. Thank you so much for the opportunity. Yes, sir.
So we'll request Professor Shekhar to talk on surgical management of cerebral AVMs.
ಮೊದಲ ಸ್ಟೈಲ್ ರಿಪೋರ್ಟ್ Mouse is working? Or? Yeah. Very good. Good. Okay. It's working, yeah.
This one.
Huh? That way, okay. I'll go back. Okay. Okay. All right. Good evening. Yeah. That's not right. Oh, it's there. Okay, thank you. All right. So thank you very much and for inviting me. And it's nice to be with friends and colleagues again. Not moving. Frozen.
Yes, sir.
It's not moving.
Morning, sir.
No, the slide is not moving. Okay. Perfect. But now, no. No, wrong lecture. This is the one. Now it's there.
Okay, sir.
Yes. Okay, perfect. All right. So we talked about what's a brain AVM, so I won't say much about it, but the important thing is the accessory pathologies. These become important as the AVM gets larger. And AVM is a spectrum of different vascular malformations of the brain. You have capillary malformations, which are only seen in autopsy specimens. Cavernous malformations are CAV-MALs, which are kind of AVM, but its vessels are dilated and the feeders are small. Developmental venous anomaly is something that is simply a congenital abnormality of venous drainage, and it really doesn't belong in this. However, you'll see a lot of patients because the doctor sees the MRI or somebody sees the MRI, they get excited and the patient is referred to you. Sometimes they are associated with cavernous malformations. They are in the vicinity. So in such cases, you have to be careful that you don't damage the DVA, particularly if it's a large one. And then you also have AV fistula. So the AVM, in effect, is a combination of different grades of fistula. So you have smaller fistula and a bigger fistula, but you also have sometimes, particularly in young patients, you'll see single fistula between the artery and the vein. And then lastly, in the same slightly different category are the dural AV fistulas. They don't actually involve the brain. Rarely you can have combination of both PL and dural AV fistula. So when I was a resident, it was always said that AVMs are congenital, but in reality, they are not congenital because thousands and thousands of ultrasounds have been done with fetuses, and you never detect an AVM. The quality of ultrasound is actually very high. You don't see any AVMs. Most are developmental. That means that they develop after birth. However, there are some genetic factors and angiogenic and inflammatory factors. And the evolution of an AVM, of course, involves the growth of the nidus, and then there are flow-related perinatal aneurysms, venous stenosis, aneurysms, and thrombosis. All these come into factor. And the symptoms, of course, the most common one being rupture, but you can also have seizures, Steele syndromes, and headaches. So the incidence of a newly symptomatic lesion is 1.3 per 100,000 population. So that's approximately 1/10 of brain aneurysms. So brain aneurysms are about 10 per 100,000 population. On the other hand, the prevalence meaning if you survey the entire population, how many people will have AVMs at any one time, is 10 to 18 per 100,000 population. So that's about 10 to 18 times the incidence. So not all of them, of course, present with hemorrhage. The bleeding rate for unruptured AVMs, this is a somewhat controversial question because it depends on the studies. Aruba trial showed a lower bleeding rate, whereas the studies of patients from Helsinki. That showed a much higher bleeding rate over a period of time. So I always tell patients it's 2 to 3% per year. Of course, there are risk factors, as you had addressed, special risk factors which increase the risk of bleeding, namely hemorrhage at presentation, deep location, deep venous drainage, associated aneurysms, venous stenosis, and small versus large lesion. So this is a natural history. ANDRA, I think, was a remarkable study because they really followed a very large number of patients from Finland, Finnish patients, untreated, and a very large group of patients. Whereas Aruba, of course, was a shorter follow-up. The bleeding rate in the medical group was 2.4%. So coming to the classification system, this is very important because no one system is still perfect, although most of us still follow the Spetzler-Martin classification system. The thing to keep in mind is that the Spetzler-Martin system was devised based on the surgical series of Charlie Wilson many, many years ago. And at that time, surgery was the only option for the patients. And they based it on the risk of what was happening, risk of surgery. And then you have the Ivandro Oliveira modification, the Lawton Young, and then I have my own system which I use for surgical stratification, how to perform surgery. So this is the Spetzler-Martin classification, and very important to note that the size is 3, less than 3, 3 to 6, or more than 6. But nowadays, we very rarely operate on an AVM more than 6 centimeters in size. But the system also never specified, is this average size or is this size in one particular dimension? So we don't know actually what were they talking about. So the location of eloquent versus non-eloquent, again, there are questions about what does it mean by eloquence. It's actually a term that was coined by Dr. Charlie Drake to indicate motor, sensory, and speech areas. Dr. Spetzler, you included also deep nuclei such as the thalamic region and deep cerebellar nuclei. Venous drainage, deep versus superficial. What is the significance of venous drainage? Almost all AVMs that are starting out superficial, when they get large, they will point toward the ventricle, and even sometimes don't see it on angiogram. At surgery, we see deep venous drainage or deep feeders. So, on the other hand, if you have a deep-seated AVM, it's a different matter altogether. So the Lawton Young supplementary grading system was devised by Mike Lawton and his colleagues to improve the validation of the Spetzler-Martin system. Basically, the additional points are the age, whether or not the AVM has bled, and the compactness of the nidus, which is very important when you're thinking about surgical treatment particularly. So how to decide whether and when to operate an AVM, and I make the decision based on these factors. So the most important things are the size and the location. So the size, the size actually exponentially increases the risk. So if you look at the risk, it is not linear, it's actually exponential. So as the AVM grows in size, the risk increases exponentially. And the location, of course, whether or not it is superficial deep, eloquent, posterior fossa, brainstem, etc. And then also multiple deep feeders. That makes the AVM very difficult to treat. So choroidal, lenticulostriate, and vertebrobasilar. Of course, age, very young and very old. Hemorrhage always favors surgery because the clot will often create a pathway for the surgeon to operate on, and the stakes are higher. So the AVM has declared itself. So hemorrhage favors surgery. However, in the acute phase, sometimes you may end up leaving AVM behind because the hemorrhage obscures the AVM. On the other hand, unruptured AVMs, you have to carefully weigh the risk versus benefit ratio. Diffuse nidus versus and extensive collaterals. This make the AVM difficult to define it during surgery. This is one of the things that Professor Raghavendran was talking about, that the PL collaterals. And not to be counted out are the experience and expertise of the team. And when I say team, I don't mean only the surgeon, the assistants, the endovascular, the radiosurgery, intensive care, all of these things, the hospital where you're operating, are all very important. You know, everybody knows that if you are working in a hospital where, you know, you don't do a lot of neurosurgery, that's not the place to operate an AVM. And the last question is, when should you operate after hemorrhage? And we'll come to this in just a minute. So now there are obviously 4 modalities for treatment of an AVM. You have endovascular embolization, microsurgery removal, radiosurgery, and simply medical management. Now, with the endovascular embolization, our own, based on data from our own institution and also other places, I feel that for small compact nidus, they may be curable. Now we come to the venous embolization, transvenous technique. It is popularized in Europe at the moment and a few centers in the US. The problem is the risk is fairly high. So some of them using transvenous embolization in conjunction with transient cardiac arrest. However, those types of AVMs where it's being used are frequently readily amenable to surgery with low risk. So I feel that that is not, at the moment at least, it's not something that should be used by many centers. For larger lesions, the main thing is the risk reduction for microsurgery. So the AVM, the flow is taken down in a graded fashion. Of course, all the surgeons want the deep portion of the AVM to be taken out because that's the most difficult part. It's very difficult to really take out the deep parts of the AVM with endovascular embolization. Microsurgical resection, we'll talk about it. Radiosurgery may consist of either single stage or multi-stage. The maximal regression takes about at least 3 years in many cases. And of course, if it's a ruptured AVM, the patient remains at risk for rupture until the AVM is completely regressed. And we also have cases where the AVM appears to be cured by radiosurgery. However, the patient presents with repeat hemorrhage. So that's also something we're seeing. And medical treatment, of course. So this is experience in our center until 2019. We haven't tallied the numbers in the last 4 years. So we have AVMs treated, microsurgery, and radiosurgery, very few cases, radiosurgery, and then very few patients treated only by endovascular embolization. Most of the cases with endovascular embolization were followed by microsurgery. And an endovascular embolization followed by radiosurgery, again, a very few, only for high-risk features. So, treatment of ruptured AVMs, we do not wait for the clot to dissolve. We have data we have published that show that you can operate within the first 3 days. On the other hand, we don't usually perform super emergent surgery, meaning we don't operate on the patient unless a patient is herniating because, what we'll do is we may do a decompression and nothing else. Why? You don't have optimal circumstances for the treatment of an AVM because optimal circumstances requires, a good anesthesiologist, maybe the ability to transfuse blood, a good nurse, and then the surgeon has to be in good condition, and operating at midnight on, an emergent situation is not a good way to manage an AVM, treat surgically. So microsurgical resection, of course, specimen grade 1 and 2, yes. Grade 3, usually we do embolization followed by surgery. Grade 4, if it is a favorable location, we will do that for ruptured AVMs. Grade 5 AVMs, very rarely we do it, we treat, and then palliative embolization is used some cases. Now, unruptured AVMs, this is a big thing, and the question is, it's controversial, and everything is based, the controversy is created by Aruba trial. A lot of the things have been gone over by Professor Raghavendran. So Aruba results, these are the results of Aruba trial, and the majority of patients were treated not by surgery but what is called interventional therapy, but the interventional risk of intervention was much higher than generally published data. So that is one of the major problems. So there are a lot of critiques, a lack of physician accreditation to enter the trials. Because I was actually a participant in the Aruba trial, but none of my patients could be enrolled because the patient will come and see me and I'll tell them, you know what, you have unruptured AVM and we can randomize you to no treatment or medical treatment and then, treatment, surgical treatment. The patient said, no doctor, I want to have surgery. So I think I saw nearly 20 patients and nobody wanted to be enrolled in the Aruba trial. But the problem is a lot of the people that had enrolled patients had not treated even 10 patients with an AVM. And as you know, with AVMs, the experience is very important. So it's really a trial of embolization or radiosurgery versus medical treatment. This is one of the things that we're talking about. Very few people underwent surgery. And much higher complications of embolization than previously published. The main reason is, in a lot of these cases, it was intent to cure purely with embolization. And with embolization, as the percentage of AVM treated increases, the risk of hemorrhage also increases. And there were not surgeons who could also manage the complications. And also there was no stratification, which is very important. And and everyone knows now that it's very important to look at high volume centers, and they were not the case. So, and short-term follow-up, all of these things have been mentioned. So we looked at a number of, we looked at our own data and published what's called the Aruba, results of Aruba eligible patients. In our own center, patients could have been enrolled in Aruba but didn't get enrolled. And what were the data results? They were much better than the Aruba trial. So that means that, although we didn't have a randomized trial, and Mike Lawton then published similar data as well. So we can move on to preoperative embolization. We, of course, there are a number of embolic agents, and Onyx is now still the preferred agent, but there are newer agents coming out as well. For Spencer Martin, grade 1, of course, is almost never embolized, but grades 2, sometimes we do it just as a marker to show where is the AVM, because some of them may be hard to find. Another thing that we are using frequently nowadays is intraoperative ultrasound. We can localize the AVM better. And for larger AVMs, stage embolization can reduce the flow in a graded fashion and may reduce the risk of normal pressure perfusion breakthrough. And it's very important that the embolization is done as part of the surgeon embolizer team, because the surgeon wants a certain part taken out earlier to make it easier for surgery. On the other hand, if it's pure embolization, some other vessel may be easier to, because I was doing myself sometimes, I don't do it anymore, but I know a lot about it, and then we talk a lot, and then we say, hey, this is what should be. And then when you do more than 70% embolization, the AVMs, there are a couple of things that happens. One is that it becomes a mass. It's harder to retract and remove. The second thing is also it greatly increases the risk of post-embolization hemorrhage. So if that ever happens, then the AVM should be operated fairly quickly. So when you are embolizing, there are basically 3 types of vessels, and this pertains to all AVMs. So when you have this type of en-passage vessel, so basically the vessel is going on to supply an important portion of the brain, but in the way gives off these branches. Now these are very difficult to embolize. This is the ideal one, where there's a direct feeder going into the AVM and then we have veins. These are ideal for embolization, and of course also for surgery. This is something that you should find. And then this is the PL collaterals. This is one of the things that Professor Raghavendra was talking about. That AVM is an extensive collateral network, and you have trouble deciding where is the nidus, which is the collateral, and sometimes you have to go beyond the nidus to remove this. Otherwise, not only there is a risk of recurrence, but also a risk of postoperative hemorrhage. Now, stereotactic surgery, radiosurgery, we talked about it. I myself do some gamma knife on some patients. This is Dr. Lunsford, who is my former colleague, and he's one of the pioneers of radiosurgery. And so the question always is it single stage versus multi-stage radiosurgery, and there are some late effects as well, which we've seen in a few people. So here's a patient that was treated by radiosurgery, posterior callosal, periventricular AVM, which was grade 4. She presented with very bothersome tinnitus and a whooshing sound and a 3 centimeters AVM. She was treated, and this, you can see, it's all deep feeders from the posterior choroidals, and mostly, of course, there are pericallosal feeders as well. She's never bled. And this is an ideal lesion for radiosurgery because it's just not really eloquent areas. The problem is when you start treating larger volumes with radiosurgery, the patient develops significant brain edema. So over a period of 1 or 2 years, they develop blood edema and sometimes seizures. Some of that can be treated with Avastin or steroids, but that can be very bothersome to the patients as well. So this is the gamma knife treatment plan, and then the AVM responded quite nicely. But of course, the patient now has other symptoms. So this is a little squirrely patient. She has other symptoms. The AVM is gone, however. So surgical removal, I'll start with this case and then talk a little bit about the nuances of surgery. So this is a 21-year-old female presented with an acute onset of severe hemiplegia and sensorium loss. And she's 10 weeks pregnant. And you can see that this is involving the motor sensory area of the cortex. And this is the SM or Specimen Martin grade 3, pretty large size, and it's oriented toward the ventricle. So here, now almost if this were an unruptured AVM, we probably won't do anything. But on the other hand, the AVM has declared itself. She's ruptured and she's also pregnant. So no doubt that this was early in our experience. So we did multi-stage embolization of this AVM. But at that time, we were also steaming the catheters, the microcatheters. And that's actually very bad because it makes it get stuck, and we were embolizing heavily. And the catheter got stuck, and I said, fine, forget it, don't worry about it, just cut it off here and leave it, and we'll get it out. And so the AVM was embolized, and here you could see, the question is actually, where is the AVM? The AVM actually expands as it goes in. So here it only seems to involve one gyrus, and on the other hand, as you go deeper, it expands. And you'll see one thing, that when there has been onyx embolization, the surrounding brain is, why did it get, something happened. That's a catheter. I'm taking it out all the way from the groin. Battery is running low. I think it's just not, the power is not connected. It's okay now. So one thing that I don't like to do, generally I don't put any retraction on the brain, and frequently I just put retraction, if anything, on the AVM itself. The problem with a heavily embolized AVM, one of the things I want to show you here is that the AVM is almost acting like a tumor. It becomes a mass because of so much onyx inside. And this is toward the end. And this one was removed, and post-operatively, I try to keep the blood pressure below 120 for at least 24 hours. And the post-operative angiogram with a good resection and minimal weakness. Sorry. So now move on to the nuances. So it's very important to have a dedicated neuroanesthesiologist. So, same anesthesiologist who usually does hernia surgery or something else, orthopedic surgery, is not the ideal person. So it should be AVM surgery requires dedicated neuroanesthesiologist because there is a potential for excessive blood loss. Sometimes you have to do mild hypotension. And then post-operatively, the systolic blood pressure has to be controlled as well. We do employ neurophysiological monitoring. Awake surgery is not, I don't find it to be useful. The patient position should minimize brain retraction and protect all pressure points. And sometimes we do intraoperative angiography as well. And oftentimes we do ICG angiogram. The ICG angiogram is not good for the deep-seated vessels. Neuronavigation is helpful to plan the craniotomy. We can also use ultrasound after you open. And always the craniotomy has to be bigger. Sometimes we think the AVM is here, but the AVM is actually more extensive. We have to enlarge the craniotomy. So the initial steps, we expose the AVM, and we will oftentimes use a preliminary ICG angiogram, and we'll perform arachnoidal or PL dissection around the AVM. What I like to do is to put temporary clips on the major vessels and then take the arteries which are just going into the AVM and then take the temporary clips off. And you need to check all the venous drainage. And this was the one question that Professor Raghavendra has mentioned. Well, should you take a vein or not? So if it's a small vein, I will take it to facilitate dissection. But rarely that can prove to be problematic. So the most important thing in dissection is that you want to use bipolar cautery without sticking. But the important thing here is the cautery depends on the flow rate through the vessel. Because keep in mind that all these vessels have very thin walls. And they don't stick, you can't cauterize them if the flow rate is high. Because two things are not there. One is the vessel wall is thin, and the speed of flow or the speed of blood is conducting the current. So it's better to slow down the flow with a temporary clip and also use a very low power. I like to use an irrigating bipolar, use a very low power of the bipolar cautery. And this is something that you have to discover for yourself. What is the right one for you? For perforating in deep vessels, what I like to do is to isolate, put a temporary clip on it, and then cauterize, and sometimes you can put small permanent clips. When you have a lot of bleeding from an AVM margin, that means that you are leaving behind a residue of the nidus. So it doesn't mean that it's just the AVM that's being, it's actually something is being left behind. Most of the time, if it's bleeding from the nidus itself, you can control it just with gentle pressure rather than trying to get excited, putting carotenoids, etc. And again, I mentioned that retraction can be placed on the AVM and not the brain. And when the nidus is diffuse, you may have to work on inside white matter. Always we like to work in the plane between the nidus and the white matter, but if the nidus is diffuse, that cannot be the case. And if it's near the ventricle, of course, there are a lot of thin-walled arteries, arterioles. That's where we have problems. In the final steps, the major veins must turn blue, and you can do ICG angiogram at the time again. And I always put a temporary clip on the vein to see if there's no bleeding from the AVM before I take it. And stage removal, people have talked about it, but I very rarely have used it. The only place sometimes is very extensive AVMs. You can think about that. That means that you don't actually take the veins, but you take a lot of the AVM and then you use a different approach to remove the remainder of the AVM. And I mentioned that keep the blood pressure low. So what are some special problems? You can leave some AVM behind. This is more likely to happen if the patient has had prior hemorrhage or prior embolization, because the embolization or hemorrhage, it obscures certain parts of the nidus. There could be difficulty with the retraction of the AVM. I showed that, where the onyx makes it. Early damage to a major or single draining vein. This is a very difficult problem. And when that happens, there's nothing you can do. Just control and just quickly move, keep moving. There may be a lot of blood loss. Normal pressure perfusion breakthrough, I'll show you this, but it's very, very rare. Happens only with large AVM, very, very large AVMs. Postoperative hemorrhage happens with unrecognized residual nidus. I think everything shut down. So that means that it's time for me to stop the lecture. Okay, to go? Yeah. All right. So now we'll come back to some cases. So this is a patient with a deep-seated AVM. So look at the AVM, it's in the capsule right here somewhere. But the AVM has created a pathway for us through the hemorrhage. So we can actually follow the clot. It's just a matter of carefully following the clot without damaging the surrounding brain. The AVM is small. And this is the clot, you can see in different planes, and you can see that this is the nidus. And you don't need radiosurgery for this because you can get to the AVM. It's better for the patient. So here you see that I found the superficial location of the clot, and you don't need anything other than just slowly follow the clot. And as you follow the clot, there is a little bit of retraction, just progressing slowly along the clot. And the problem, of course, is you don't really know where the nidus is, but you can get to the nidus. It's not going to bleed a lot. It's there is a nidus. And you can also, one thing you can see, this is one of the things that I was teaching my fellow and my chief resident. See how I work on the bipolar. I don't actually close the tips very briefly. I often try to cauterize with the tips unless there is AVM is almost out. So that's the end of the AVM. And so we put one temporary clip on a feeding vessel. and the AVM comes out. And this is the post-operative, and no problems and complete recovery. Now here, on the other hand, you know that right off the bat, this is going to be a tough one. This is a patient with a deep-seated caudate, an anterior capsule AVM, Spessa 4. And today, if I were to operate on this, I'll need to think about it very carefully because this is pre-Aruba trial. The patient, however, was in severe distress. You know, she was having severe headaches every day. She was developing hemiparesis and so on. And so what we did was we did multiple embolization. The question was, where are the lenticular striates, or what are they supplying beside the AVM? So here's the M1, and you can see that all the feeders are coming off the lenticular striates. Very few from the cortical vessel, cortical branches. But there must be some supply going to the deep portion. We just don't see it. And so this one basically, and it's not presenting on the surface, so I'm opening the Sylvian fissure, and the AVM is actually located in the deep frontal area right about here. So this is temporal lobe and MCA, and you already see some embolized vessels. And the question is to decide, I'm putting a temporary clip. And then just taking down only the actual feeders that go to the AVM. And again, it's a very enlarged vessel, but putting a temporary clip on, and now I'm opening one of the sulci leading towards the AVM. So the AVM is actually in this area. And nowadays, I frequently will use also intraoperative ultrasound. It's very useful to find the AVM. Of course, you can use navigation, but navigation shifts a little bit once you're inside. So you could see a lot of the embolized AVM. I will sort of advance this a little bit. So once you find the nidus, the most difficult part is actually the deep part. You see that there's no way to embolize them. So you have to just put some clips on, temporary clips or sometimes permanent clips. Eventually, I will take a lot of these clips out. And this is going to point toward the ventricle. So how long does this take? I always say 1 centimeter, 1 hour. So 4 centimeter AVM resection for me, just 4 hours. But if you're just patient at the beginning and coming around, it doesn't take that long. So there's no reason to rush, but you just have to follow the same kind of strategy. So still I'm trying to stay in the plane between the brain and the gliotic brain and the AVM. So, and here finally the AVM is resected, and so this patient did actually pretty well. She had some kind of a weakness post-op, but recovered completely and without any deficit. So this, going back, this is a pediatric AVM. It's just located in the brainstem and cerebellar area. But because he had a hemorrhage, I decided to operate on him. The main question is, this is fed from the pica, and there's actually an intranidal aneurysm. The question is, which part is supplying brainstem? But, 2-year-old, you can take some chance. And this was operated by far lateral approach. And it simply shows the so we are approaching And here's the enlarged ICA and lower cranial nerves. The AVM is actually right there. So that's from, it supplies both from ICA and PICA, actually. See, the pediatric people, the children, the vessels are even thinner walled. And you have to use very low power of I like this irrigating bipolar, but of course some surgeons prefer the non-stick bipolar with some external irrigation from the assistant. So there are branches coming out from ICA and PICA. This was going, here is the AVM going into the brainstem, and this was removed, complete resection in this patient. So that is the end of the procedure, and so postoperative angiogram, he recovered well. This is a patient with a trigeminal and pontine AVM, and you could see that this patient presented with trigeminal neuralgia and was discovered to have this AVM, and there is a big aneurysm on the feeding vessel that comes right off the brainstem. So the question is, does it go anywhere? But the key here is good exposure, adequate exposure, because you want to see the aneurysm and the AVM as well. So I use a petrosal approach, and this could be, the whole thing could be seen and resected. And here is a clip on that vessel feeding into it, and then the AVM. And she had some transient problems which recovered completely. Now this is a patient with a failed gamma knife treatment, large known left frontal AVM. So she had previously already had radiosurgery many years ago. She came to us, and she came with a hemorrhage. So what we did was we treated some aneurysms that she had. She had an ACOM aneurysm and a PCOM aneurysm, and then so we said, well, these are the high risk areas, and then she got radiosurgery. However, so this is the initial presentation. You could see that it's a large AVM. It involves multiple areas, a lot of calcification as well. So the, here's the AVM and left hemisphere, supplied from both sides. So she had clipping of the aneurysm and radiosurgery multi-stage in the hope that it'll regress. But 3 months after the radiosurgery, she re-presented now with a big hemorrhage. So here is a second one. Of course, you can say the radiosurgery itself hasn't had enough time to work on her. However, now the surgeon's job is a little easier. Why? The hemorrhage has disconnected the AVM from the major and critical parts of the brain, namely the capsule and so on. Of course, the patient also is more significant deficit. She has GCS7, severe right hemiparesis, etc. So I'm encouraged that we got to get this AVM out. So this is some embolization of the pericallosal callosal margin. So those are the difficult ones for me. So my colleague said, okay, please embolize these vessels, the pericallosal and the callosal marginal that are going into the AVM. These were embolized, and then of course, I won't show you the whole thing, but basically we have left frontotemporal and right frontal craniotomy, and we also use orbitotomy so that we can see all the sides, all aspects of the AVM. And we start with opening Sylvian fissure, and then, this is just a tedious procedure, just coming around the AVM and disconnecting the vessels and so on. And there is a catheter tip which is detached, of course, from embolization, which again, I got it out. And then here is the first cranial nerve, and it's helpful to have that basal approach as well. So here is the conjunction between skull-based surgery and vascular surgery, so that you can get I already talked about petrosal approach, and we're talking about orbitotomy. So you really want to see circumferentially around the AVM without retracting the AVM too much. So it's helpful to have skull-based surgery. Here are some vessels which have been embolized, but even then you have to take them sometimes with some clips, because some of the vessels may open up even though they're embolized. So here's the olfactory tract again, and but I would, I like to use these titanium hema clips, but the downside is it's not easy to take them off, just like you saw there, rather than mini aneurysm clips. These are cheaper and also lower profile for MRI. And we are just coming around the medial and basal aspects of the AVM. And then, of course, here, this is a completely removed AVM at the end. And this patient actually, that's the bed of the AVM. She did very well. This is her post-op MRI and angiogram. She went to rehab, and then 5 months later, she was near complete recovery, still had memory problems, and she has some impaired vision in the left eye from the bleeding. So here's a patient where I had normal pressure perfusion breakthrough. So this is a 31-year-old man who's a computer engineer. He came in with generalized tonic-clonic seizure. So I said, okay, this is the right frontal lobe, okay, grade 4 AVM, we can offer surgery. This one, today, I will definitely think twice about it. He got some embolization, and we came for surgery, and embolization was done. And many stages. So he was operated, and everything seemed to be going well. However, suddenly, toward the end, everything started to bleed. So all the vessels surrounding started to bleed. You see this? Even though that area was previously quite dry, it opened up, started to bleed. So there's nothing you can do at this stage other than put lots and lots of temporary clips and just get the AVM out, and you think that you got the AVM out, and keep his blood pressure very low for a week or so. And you see the number of temporary clips that are in place, temporary or permanent clips. So that's his bone flap was left out for 6 weeks, and lots of clips there. And then, however, he did fine. He actually recovered, and I went back and did a cranioplasty, and I took out most of these clips. This is the damaged area of the brain because of the AVM primarily, but he recovered. Fortunately, it's a frontal lobe already dysfunctional. But I'm just showing you this very, very, very rare case of normal pressure perfusion breakthrough with a large AVM. So I actually would like to stop there. I just tried to show you some nuances and at the same time some potential problems during AVM surgery. Okay, thank you so much.
It was a wonderful lecture, sir. Now it's open for discussion. We have another 10 minutes before we move on to next topic. Any questions from the floor?
So the question whether to take the vein or not.
Vein.
Vein
Uh-huh.
to take. Many occasions the moment I have a feel that this vein has to be taken.
Mhm.
However much I try to avoid it, ultimately, once I take that only I can have further progress. Because I have seen that swelling of the AVM,
Brain.
but most often we get away with that. The whole brain starts pulsating at a different rate once that vein is taken out. This is your take on that.
Well, mostly before I go in, this is one of the very important things. Before we start operating, you need to have already developed a mental picture, three-dimensional picture of the AVM. So, believe it or not, this is much easier to do if you work with the person who's doing the angiogram. So, one advantage of the embolization and the interventional radiologist or neurosurgeon who's doing embolization is that they get a very minute idea of the anatomy, AVM anatomy. As surgeons, sometimes we don't have that because we see the pictures, we say go in there, and in the reality is that there is something there, the veins are going here and there and so on, and we just don't have the concept of where are all the veins going and which are the ones which are important. So clearly, the AVMs are, number one, multi-compartmental. In other words, there are different compartments of the AVM which are being drained by some veins. On the other hand, there's also collateral circulation inside the AVM. So, taking some veins may be inconsequential. I would say that it's very important to avoid taking deep veins. Of course, you don't often see that. And the big ones that are dangerous. Otherwise, I frequently will take the smaller veins. If you have any worry, I will put a temporary clip on the vein and then watch it for about 5 minutes before taking it. So that seems to help. I had one case which I haven't shown here where it was a deep, it was an AVM that was sort of frontal, but then it was going towards the ventricle quite a bit. And she was trying to think if she was pregnant or something. But anyway, what happened was one vein was taken. There were multiple veins, and I took one vein. Immediately, the AVM started to bleed. Bleed, and there was nothing that could be done. I just said, tell the assistant is very important, anesthesia is important. I said, anesthesia, keep giving blood, platelets, whatever. Tell the assistant, just keep sucking. Just keep, I just keep working around the AVM, get it out. That's it. Once you get the AVM out, nothing. Bleeding stops. And the patient did perfectly well. So you shouldn't be, this can happen with AVM surgery sometimes. It's very, very, very rare, that excessive bleeding happens during surgery. It can be related to taking some veins. Or, of course, more common causes, you have some AVM left behind. So you think there is a lot of bleeding, and there's actually some AVM in that area. So you just go in and take out the nidus, it's gone, all the bleeding stops. Does that?
Yes, sir.
Sorry, yeah, experience.
Special reference to the artery which is unpassage.
Mm-hmm.
How do you identify and how do you avoid that?
So that's where I always put the temporary clip on the feeding vessel. Whatever vessel is going in, I put temporary clip. And then I take the vessels just close to the AVM, and I will take the clips off, and you can often tell on the base of preoperative angiograms which are the in-passage vessels. Of course, even in-passage vessels sometimes have collateral flow from the other side. It's not like they are purely in-passage. There is the AVM the artery has developed collateral flow from the other side. But nevertheless, I don't like to take the arteries. I like to close the bleeding down, but I don't like to take the arteries proximally. Just take them as close to the AVM as possible.
If there is a post-op bleeding in a patient who is an operated AVM, then you always do repeat angio before taking up again, or you can straight go ahead with that.
Right. I think it depends on the patient's condition. If the patient condition is bad, you just have to go back. You know that you left something behind. We always get a post-op angiogram, or rarely intraoperative as well. We have a hybrid room. We do sometimes intraoperative angiogram. But reality, the post-op angiogram is actually better than intraoperative angiogram. I feel that intraoperative angiogram, I've done it so many times, you just don't see everything. Post-operative angiogram, the detail is so much there. If there's post-op bleeding, it's almost always residual AVM. And you as a surgeon, you know where you left something behind. It's not like somebody, but if you have time to do a post-op angiogram, it's definitely helpful. So, and there were 2 or 3 cases where there's no post-op bleeding. There was a residual nidus, small one. And the patient is fine, there's no bleeding. And I said, well, I've gone back, and there were some cases where I said, well, it's a small nidus, maybe we'll do gamma knife. And that worked. It was okay because such a small residue. I felt like it was not worthwhile to go back, you know. But most of the time, I like to go back and get even if it's not bleeding and the angio shows residual nidus, what to do, you know. So you've got to, because that's the best chance to cure the patient. And also, you can't trust the patient to go home, because the patient may go home and have a bleeding, you know, so.
All patients have a post-op angio?
Everyone.
Next day.
Yeah. Every single patient I get a post-op angiogram either the next day or the same day, you know, within a few hours. And I don't let them leave the ICU unless they have post-operative angiogram. And I always keep the patient in the ICU for at least 1 day with a blood pressure very tightly controlled. Because one patient that I had years ago, I sent the patient to the ICU and the nurses weren't paying attention, intensivists, and the blood pressure was going up and down, and the patient had a hemorrhage, you know. And I'm sure there was a residual nidus as well, but it wouldn't have happened if the blood pressure was, you know, because there's so many tiny, and as he was mentioning, so many tiny vessels in the periphery. They are slightly dilated. That can let up if the blood pressure goes up, you know, so.
Is there an entity called a normal pressure perfusion breakthrough?
Mhm.
Because most of the time it's talked about, but
Mhm.
always you always think that it's a normal pressure perfusion breakthrough.
Uh-huh.
But most of the time the bleeding is because there is a small residual nidus or some vein.
Right.
So
Correct.
This has been a lot of controversies on this topic. What is your take on it?
Yeah, I think that mostly intraoperative bleeding is due to residual nidus. But there are definitely cases, like the one I showed, because I know that the AVM is out in that area, but suddenly everything starts to bleed. So I think there is, especially in larger AVMs, there is a potential, but increasingly we don't operate on those AVMs anymore. So in the older days, a lot of these large AVMs were operated, but nowadays we don't even operate on them. So I think that it doesn't exist. You know, I mean, it exists, but it's more of a ghost than reality. There are some cases, but not so many. Yeah.
There's multiple veins. There's some
Mhm.
AVMs, there's a lot of multiple veins.
Yeah.
The endovascular, when they do, they give heparin. Because these veins, we shut down, there's a chance of retrograde venous thrombosis.
Mm-hmm.
So when you see a lot of veins, in particular, do you give heparin post-op?
No, I don't give any heparin, in the postoperative phase, because everything is taken out. Of course, during endovascular embolization, heparin is given. The problem is, as I mentioned earlier, as you embolize AVM more and more and more, when we see if the venous drainage is really slowing down, we won't discharge the patient. We'll keep the patient in the ICU for a couple of days, and I will operate as soon as possible. Because those people are at risk for develop. I have had a few people develop hemorrhage. That's just the time when it happens. You know, you think, okay, it's a little bit more embo, we can do it. Okay, and then what happens in reality is the embolic agent gets into the vein. You know, or this venous flow is slowed down so much that, it develops some thrombosis probably, some of the veins. Yeah.
What is your difference between approach between adult and pediatric AVMs? Pediatric AVMs are more dynamic compared to adults.
Yeah.
In terms of follow-up also.
Absolutely, I agree with that. You do need, what I do typically is I'll get an angiogram, most of the time, younger patients, I'll get another angiogram after 6 months, even though the AVM seems to be cured. And we have a few patients, everything was totally gone. But then they came back, 3-4 years later with a recurrent AVM. And sometimes it's treated with radiosurgery, sometimes going back. But so whatever process that created the AVM, which are growth factors, etc., they're still operational in that patient. So that's why they got what you're saying is absolutely correct. Yeah.
Sir, actually it is regarding this embolization.
Yes.
If embolization is used as standalone procedure, what is your recommendation of what volume of the AVM should be embolized? If it is used as a pre-op embolization, what volume you would recommend for embolization.
Right, yeah. So any AVM less than 2 centimeters, and if it is a purely compact nidus, particularly one that is supplied by, 1 or 2 distinct feeders, that can be, you can attempt definitely embolization cure. So it has to be small, not diffuse, but compact nidus, and there had to be distinct arteries, not like multiple little feeders going, 1 or 2 distinct arteries. I think it's worthwhile to definitely attempt cure with that. However, in those patients, you need a follow-up 6 months or so, make sure that it's not recurred. Because we had a few patients that it looked like cured, but then it came back with a recurrence, In terms of preoperative adjunctive embolization, definitely anything even grade 2 very frequently L2, but certainly grade 3 and 4. But there should be very good communication between the embolizer and the surgeon, because the one that is the most difficult for the surgeon is what should be tackled first. For instance, if you have a premolar AVM, we want the most posterior branches to be taken out, because a lot of the other ones, that they're going to, you see them at surgery. If, and I'd say that's a big if, a deep feeder can be taken out, that can be embolized, but frequently it's very difficult. However, what happens in those cases, what I would do is I will open Swons fissure and I'll find a deep feeder and I put a temporary clip on it, and they'll have some monitoring, and they say, okay, this is the one that was going to the AVM. That makes it easier for a resection, because those deep feeders are the ones that give us trouble during resection. But it's not always possible. The problem is our technology is not there yet. I'm sure it'll get there. The problem is to get the microcatheter in there, safely. That means you can get the catheter in there, but you have to get it out, and there shouldn't be reflux into the normal vessels and so on. So it's a higher risk for the embolizer. So does that make sense to you?
Dr.
Yes, sir.
Shekhar. Yeah. During your talk, you said in one of the AVMs, the one going towards the thalamus and caudate nucleus, you said you would decide whether you would operate in today's world. So what would be a strategy for that? Especially these perisylvanian AVMs with a lot of feeders coming directly off the M1 or M2. It's quite difficult to get them all by any means. So what would be a strategy in today's world?
Correct. I think that if the patient is in severe distress, so that was a patient, unruptured AVM. So unruptured AVM, I think that definitely I favor probably maybe radiosurgery for that patient. If it's a ruptured AVM, I think it's okay. I would go ahead with surgery. The unruptured AVM, if the patient is in severe distress with severe headaches, a little hemiparesis, it looks like some steel is developing, I think you can definitely attempt, in that case, there were a few feeders, even though they were coming off the M1, they could get into an embolize. And the problem is, as I mentioned, in a case like this, what is the feeder to the AVM and where is it going? Where is that? Where's the feeder to the capsule? This is the problem. So that's a tough. Those are tough ones. But if it weren't, the two options I would consider for are number one, do nothing, or radiosurgery. And sometimes when the AVM shuts down, partially with radiosurgery, then you can think about even operating on the AVM at that point, But in general terms, I would say it's not, the patient is not a prime surgical candidate. But, everything changes, just like the grade 4 AVM that I showed, we did not operate, she had radiosurgery, but then she had a big hemorrhage. What to do now? I have a few people like this. So, so then the patient had a hemorrhage, you got to take a chance and, do your best. Yeah.
And as far as putting your temporary clip before operating close to the AVM, how proximally would you put it? I mean,
I usually put them on the M2 or M3 vessels. Yeah. I mean, you could see which, from the angiogram, these are the vessels going to the AVM. So if it's near the field, I'd put them on, not in the fissure, usually. Yeah.
One last thing.
Yeah.
There are quite a lot of young.
Yeah, of course, definitely.
A lot of them in training.
Yeah.
So when do you think they should start think about operating on an AVM?
So, the first thing is that you should always have worked in a center which is doing AVM surgery. So, the problem is that many of us, when I was training in neurosurgery, I didn't see many AVMs being operated. You can't believe that. But I went to fellowship, I saw AVMs being operated. I came back and I started working with Dr. Janetta. And I would say definitely he came and they had kept as soon as they came back, oh, we got 20 AVMs for you, waiting, So, and I was operating lots and lots of AVMs. But Dr. Janetta, my boss at the time, he came and helped me with some cases because I'd be working, and I said, either Peter would come in, Sheikh, how you doing? I said, Pete, the AVM is still bleeding. I said, take a break, go. And so I would go for half an hour, come back. I said, what happened? Peter, everything is clean. Oh, there was just a little residual AVM, I took it out. That was it. So he knew so what I'm mentioning there is that try to work with a senior surgeon. Very important. Somebody who has already done some of these things and they know there are things that they are doing that it's very hard to pick up. One of my fellows said, one of these cases, I don't remember, said, Dr. Shaker, suddenly you changed something. What happened? I said, well, I saw something there and I changed something. So it's very hard to communicate all those things. So that's number one. Second thing is that do not ever attempt removing a grade 3 or higher AVM at all. The first 5 years if you're training. Grade 1, grade 2 is fine, and grade 3s and grade 4 almost never. And so those are, I think, some good pointers.
What do you think about the hybrid neurosurgeons who are going to be both intervention as well as this? I think that's going to be the way forward.
There is, in my opinion, there is no such thing as a hybrid neurosurgeon. I think it's a misnomer. I think there are endovascular neurosurgeons, there are microsurgeons. There's no hybrid, because I know this because I did endovascular training myself. I don't do any endovascular surgery. Why? Because what my endovascular colleagues do, I can't, there is just no way for me to replicate his experience. We have in our center three other neurosurgeons who are hybrid neurosurgeons. Of them, only one person is actually truly a hybrid because that person actually trained in surgery under Dr. Spetzler. He came to me and I trained him for another 5 years. And then he's also endovascular trained. So he's actually, the other person was trained by me and has done lots of endovascular. He's become an endovascular guy. So I got another person. So this idea of dual training, I think, is total nonsense. There is no such thing. Dual training in microsurgery, how long does it take? At least 5 years after you finish training. That's how long it takes. But if you always have the mindset that I'm just going to do endovascular, then you take the easy path. But endovascular is not easy. There are so many nuances endovascular. So in my opinion, there is, and you can't say, well, oh, it's endovascular. No. Where is the complication? The complications occur in that little gray zone. When you think that you've done something, okay, now I'm ready. And AVM embolization is one of the most difficult things to do. You don't want to give the patient a stroke. At the same time, you want to do the right thing. So I think that I don't believe that there is anything called dual training or dual neurosurgeon. Yeah.
Thank you.
Can I?
Yes,
one
sir.
last question, sir. Sorry, I'm radiation oncologist.
Yes.
And radiosurgery is obviously my passion.
Yeah.
And a lot of senior neurosurgeons here do refer patients to me for radiosurgery.
Yeah.
To summarize the things properly, where do you draw a line? These are the cases which go for radiosurgery, and this you're comfortable doing surgery. Do you have any thoughts on that? With the clinical case which Dr. Srini has alluded to.
Yeah.
And also in your presentation, I have seen that few of the patients you have done staged radiosurgery. Is it dose stage or volume stage? And how do you see the results in both the stagings,
right,
whether it is dose stage or volume stage?
Yeah, that's good. Those are good questions. So we have a Gamma Knife Center, and I actually am one of the surgeons who work with some of these. I actually put the frame on and work with them in planning. We have a monthly conference where we actually discuss these kind of cases, and anything that sometimes the patient wants something different. You talk to them about surgery, especially unruptured AVMs. Then we have them go and see the radiosurgeon. And sometimes the radiosurgery, they come and see them and they send it to the surgeon, So those are basically cases which are going to be grade 1 or grade 2 AVMs. Now, with the larger AVMs, the kind of cases that we want the radiosurgeons to treat are the ones that they also don't want to treat, because the
surgical rejects.
The surgical rejects. But at the same time, they are also afraid because, it's a multi-stage radiosurgery. Absolutely. It's not volume, but it's a dose stage, essentially, And sometimes the results are I have several cases of whom I've treated that failed radiosurgery, even though they've gone by 3 years have gone by. But, okay, they say, well, there's a lot of edema is still there, patients having seizures, what to do, However, definitely deep-seated AVMs, with even when they're present with hemorrhage, we remove the clot. If I feel like, okay, this is not something that should be surgical, we send them for radiosurgery, see what they say. And also patients who have other comorbidities, They have some heart disease, they have other things going on. So those are all candidates should be considered, I think, for radiosurgery. And, the downside is that we have not seen any real progress in radiosurgery. What do I mean by that? Okay, so we have, better dose planning and better planning of now it's much easier with the gamma plan is constantly improving. But what I like to see is some sort of radiation sensitizers or something else or some other technique which makes AVM more susceptible for the radiation effect. So we're not seeing anything like that. Maybe it'll be a combination of antibodies, give antibodies against some of these growth factors and combine it with the radiosurgery. That'll be nice for the patient, What do you think about that?
So we
are concluding. Okay.
Thank you so much, sir. We will continue to have the discussions after start off. Now I invite Dr. Balamurugan for his talk on approach to aneurysmal SH. It's not talking.
Getting lack of time. I'm sorry, Dr. Shekhar. I think we may have to trouble you with continue with your talk so after your.
Oh, I see. Okay, no problem. We'll just start with the next one. This either you just open automatically or not that one. Either that's that one. No, I'm okay. Okay, thank you very much.
Sir, in the online portal also, there was one question by Dr. Suresh Mathuria. He was asking about the preferred embolizing materials and how much hours you required to prepare that embolizing materials.
The preferred embolization embolic agent is Onyx. We're using it. But usually Onyx 18, but sometimes we use Onyx 32, if it's earlier on. That the question? Yeah. There are newer agents that are being tried, but nothing has. The downside of the Onyx is, unlike NBCA, it takes time to polymerize. But NBCA, you can product the microcatheter and then just shoot, you have to get out. But Onyx is it's a little more forgiving as well. It takes time to develop. That's the only downside of Onyx. Yeah. Okay. All right. So it's okay. Yeah. Thank you. So this is about bad things. Bad things happen during aneurysm surgery, and this is but general talk about complications and how do you deal with complications. Okay, so bad things happen to patients, and of course also the surgeon and the team. It gives high stress to the surgeon. The surgeon gets very nervous, starts yelling and swearing. The entire team gets nervous and angry. The situation gets even worse, and at the end the patient suffers. So just talking about aneurysm surgery in particular, I would say do not operate on ruptured aneurysms 9 a.m. to 6 a.m. The exception is ruptured MCA aneurysm patients, the large clot who are herniating. Then you don't have a choice. And then develop the A team for aneurysm surgery. What's the A team? Anesthesia, scrub nurse, circulator assistant, etc. Monitoring if possible. And if you're not by nature inclined to have patience, and there are surgeons, you know them, by nature they don't have patience and they can't cultivate it, you're not good for vascular surgery. Those are people, okay, you could do tumor surgery, you could do something else, but vascular surgery requires a lot of patience. So learn meditation and anger management. In my own personal case, I believe that belief in a supreme being, whatever it is, doesn't matter. Brahman, Jesus, Allah, whatever, to help you and your team. So we talked about the A team. So the equipment, all the equipment should be there, and make sure that they are functioning, particularly aneurysm clips. Believe me, there are cases where I'm operating on aneurysm. I said, give me the clips. And they say, okay, no, they're not here. The tray is empty, or the tray is wrong, and it's somewhere, they're being, or there are 2 cases going on. We only have 3 trays, and the 3rd tray is missing, something like this. So these are very common things that you encounter anywhere. 3rd section, we'll talk about this. Always during cases, aneurysm and AVM, a 3rd section which is independently connected to the wall section. Frequently nowadays, they have this machine, which is very good for the patients and everybody because the blood goes through, there's no contamination, etc. But that machine can fail. So you need to have always the 3rd section. And then, of course, you can give burst suppression or possible adenosine arrest. The anesthesiologist should be prepared for transfusion in almost all aneurysm or AVM cases. And this is, by the way, very important these days because their side, they believe that they should never give blood. So sometimes they haven't even typed and crossed the patient, or they don't have a large bore IV. So this is very important. And there is also, of course, you may have to give plasma and other agents. Very good communication is very important. So you need to communicate and then let people know there's a problem. With aneurysm surgery, I always like to say that it's very important to have proximal control, skull-based approaches for complex cases, and keep the field clean, as dry as possible. So how to react to acute and bad complications? The worst complication is just intraoperative rupture and bleeding. I always say the most important thing is panic. You should panic, but for 10 seconds. 10 seconds on the clock. If it's possible to get it down to 5, it's even better. Panic, that's a normal reaction. Get it out. Say a prayer if you have time, but inform your team. That is, if they can't see it on the video screen, they don't know. The anesthesiologist is, looking at their phone, and the circulating nurse is looking at her phone, and nobody is paying attention. Only you and the assistant know something is going on. Sometimes the surgeon knows something bad has happened. And if you really need it, you may want to get help from a colleague. So let's say that you're a senior surgeon, you're working with a resident, something bad is happening. Don't be bashful or don't be ashamed to call a colleague. Nothing bad about that, because you like to help them, they like to help you. And if it's possible, talk about this beforehand. If it's never happened, it's going to happen to you. So what are some major complications? Severe brain swelling can be encountered. This is something that happens particularly during aneurysm surgery. Can also happen AVMs. Bleeding from the aneurysm can be mild, moderate, or massive. Of course, it can happen just during craniotomy. So I always like to have ruptured aneurysm, like to have the blood pressure a little over. I'm actually there making sure that the blood pressure is not high. Can happen during dissection or clipping. Then you put the clip on and you think everything is okay, but there's no flow in the arteries after clipping. So you put a Doppler on, there's no flow, or you do an ICG, there's no flow. Occlusion of critical peripheries. This is something that sometimes you don't know. If you're doing monitoring, the neurophysiologist says, well, the MEPs went out, SEPs went out. So you're trying to figure out what happened here. Is it a problem with the lenticular striate? Is it a problem with the anterocoroidal? Something like this. And occlusion of critical peripheries. Then you can have delayed strokes, of course, related to clipping, brain swelling and hydrocephalus. And of course, you can, when you do a post-op angiogram, you can have residual aneurysm or severe stenosis. So brain swelling obviously makes aneurysm surgery very difficult or impossible. Potential causes are high-grade aneurysm patients, poor anesthesia, intercerebral clot, or rebleeding. And what are all the standard mitigation measures all the neurosurgeons know? But sometimes the skull-based approach can be helpful. Opening cisterns, third ventriculostomy by opening lamina terminalis, removing clot. Rarely you can remove less essential brain, such as temporal tip. And of course, bleeding so once the bleeding happens, you don't have time to think. So you're just relying on your reflexes, learn from previous. So it's like facing a fast bowler during cricket. You don't have time to think. Or a spinner, doesn't matter. You're not thinking. You're practicing your reflexes. So you already sorted this out in your brain. What are you going to do? So then you just follow that. And teamwork is extremely important. Everybody has to work together and pull together. So you got to clear the blood, get proximal and distal control if it's possible. And I mentioned the assistant is very important. The assistant will keep the blood, the field clean. And the third suction becomes extremely important because it's not uncommon that the suction will fail. So why? Because the suction became clogged, there's too much blood, the bag is full, whatever. These can happen. And then anesthesia can help you with induced hypotension, transient cardiac arrest, etc., and replacing blood. So here there is an event from the Mahabharata war and Kurukshetra war, day 12. So the large army of Samsapakas, they've taken a vote to kill Arjun that day, or they're going to all die. So there are 1,000 of them. They're fighting, surrounded Arjuna, and they're shooting arrows from everywhere. The sky was covered with arrows. And so Krishna said, Arjuna, are you alive? I can't see anything to drive this chariot. So hearing this, Arjun, he launched the Vayuvastra, wind weapon. The wind became like a gale force and cleared the sky. And so Arjuna could shoot the arrows at his enemies. So in the modern day Mahabharata, when the field is filled with blood, that's like, okay, clear the blood so we can see where the heck is the bleeding coming from. So it's very important. Same analogy. So one bad case, I will show you what happened. So this is a 40-year-old man was riding a bike. He felt dizzy and he ran into a truck. And he got admitted, severe headache on exam, he had subarachnoid hemorrhage. But he got admitted to the head injury team. We have teams, vascular team, head injury team, because they thought this is post-traumatic subarachnoid hemorrhage. He had a CTA, which was felt to be normal, but the CTA was reviewed by the radiologist, and then they said, no, this looks like an aneurysm. So the patient goes to angiogram the next day. Ventriculostomy is in place. So the angiogram identified what looks like a dissecting aneurysm of the A2 vessel. You can see here, it's a dissecting aneurysm, A2. And so Raj, my interventional colleague, said, Sheikh, I want you to, I don't think I want to. I said, Raj, put coils, put a balloon and put coils. He said, no, I don't want to put any coils. This vessel will be dissecting and I'll occlude it, so it should be operated. Meanwhile, I'm in clinic. And so I told the chief resident, so what happens? The patient is in the angio suite. He did the angiogram. The patient is grade 3 already. One of the nurses in the angio suite decides that the patient needs to have an NG tube. No one has written an order, actually. We can't find an order for this anywhere. Somebody said, oh, the patient needs an NG tube for medications. So he decided to put an NG tube. So he was trying to put an NG tube, and the patient ruptured. So imagine this. This can happen in every one of your hospitals. It happened in the hospital where we treat aneurysms every day. And then, of course, I go back and try to recount the situation. And what do you do to risk management and all these people? Who do you tell? Anyway, now the patient is grade 5. From grade 3 to grade 5. So has had a big rebleed. And then they said, well, so the only thing is that, okay, we had to do something for this patient, young patient. So I said, let's get him to the OR. So the only thing is that the aneurysm is pretty brittle. He needs the intrahemispheric approach. You can't just get there for a TRL approach because the vessel is going to be occluded. So the patient gets into a small operating room, not a typical one. The circulating nurse had never scrubbed on any neuro case before. She gets put in there. The second, 2 suctions are connected to the Neptune machine. Okay, that's the machine where everything goes through. So, meanwhile, I come in at about 4 o'clock or something. Brain was very swollen. So I told the resident, do this. And then the exposure was not enough. So I said, okay, we need to do more craniotomy. We did more craniotomy. And then I'm trying to find the aneurysm. I don't have proximal control. It ruptured. So at this time, everything is bleeding. Both the suctions failed, gone. And active bleeding. Luckily, everything is just coming out. But the circulator is not able to fix the problem. She's just looking at the Neptune and this and that. And I said, get help from somebody. So meanwhile, what did she do? She sent a medical student who was watching. And the medical student just meekly went up, well, Dr. Shaker needs something there, so nobody is coming. So I started yelling at the circulator, get help, So eventually somebody got the message and they came and they connected to a wall suction. In the meanwhile, the anesthesiologist, Dr. Lele, came in. He's a very experienced neuroanesthesiologist. He said, Shaker, do you want adenosine arrest? I said, yes. So he gave me, I think, 8 rounds of adenosine. And whenever he gave the adenosine stopped, I could dissect. Adenosine, dissect. So finally, I did a little bit of frontal lobectomy. I got the aneurysm clipped. Postoperatively, however, the patient has, some strokes, you can see here. And the patient actually was no flow in one of the A2s, no collateral flow. So I took the patient back and did an A3 to A3 bypass, A4 to A4 bypass. This was done, and the ICA was already clotted, ACA. So the bypass was not successful. Angiogram showed no change. And the patient then had angioplasty, but he developed vasospasm, severe vasospasm, and died. Eventually, poor prognosis, so he died. So this is the kind of thing that I want to show you. This can happen in our place, where we have operating so many aneurysms, multiple lessons. Do not operate on difficult aneurysm cases without your experienced team. Have third suction. Do not yell at people. It doesn't help. So, I mean, of course, in the moment of thing, you yell, but it doesn't help. Get help from a nursing anesthesia at the right time. And prayer is the only hope for the surgeon and the patient when all else fails. I mean, the prayer really helps you. I tell you, prayer helps. So here's a different case, large PCOM aneurysm, intraoperative rupture. This one was actually my fellow was doing this case, and I was sitting somewhere, and I said, okay, just open and get this, and started to bleed. He didn't have a proximal control. So he called me, and I came in. And of course, I know where the aneurysm neck is going to be, so that's what I'm doing. So I'm just guessing where the aneurysm neck is, and, I'm just putting it on a clip. So, and now once the bleeding is under control, it's much easier to, really find out what is happening. And, everybody thinks that I'm Mr. Cool, but I'm only Mr. Cool because I've been here before. See this? Now the only question is, where's the anterocoroidal, where's the PCOM, etc. So it's not so. See, the problem is, he also didn't open the Sylvian fissure enough. So the brain, in a case like this, I like to have more opening of the fissure, a little bit better control, etc. And then, now you can do all the things that you do during aneurysm surgery. And, then you can dissect around the aneurysm. This is actually a pretty big aneurysm. You may have to resect it and then do everything else you do with this case. And the reality is I'm actually cutting out the aneurysm and then eventually, putting just enough clips. I'm actually suturing. Third nerve was damaged during this whole thing. Then I'm actually suturing third nerve back, and it's actually recovered. So that's this is a recurrent aneurysm, different case. And again, in this case, what happened, she had bleeding, but what was bleeding was the friable ICA, disease ICA was bleeding. So here we're just opening the basal cisterns, and then you could see that in a minute it starts to bleed. And it's previously coiled. Nowadays, we might have thought about putting a flow diversion stent. But look at the artery, it's very diseased. These are the kind of vessels that could develop some problem. So I found this thing and I put the clip on. And, I'm just sort of inspecting the aneurysm and excising or dissecting it off the third nerve and so forth. Oh, this is somewhere here. There you see. It starts to bleed. What's bleeding? Is right out of the carotid artery, where I previously had a temporary clip. It's just bleeding. So I just moved the temporary clip and I actually put a stitch. So vascular surgeons should be able to do some level of bypass surgery. So here all I'm doing is putting a couple of stitches, but you can't do this unless the bleeding is stopped. So I just put temporary clips on either side, and I put 2 stitches there, and then take the one more stitch, take the clips off, and still something was oozing there. So third clip, a third stitch. It's okay, it stopped. And I'm putting a little muscle on that area to reinforce. So post-operative angiogram looks fine. This is post-op angio. Looks very good. It doesn't look like anything happened to this patient, but I do know that something happened there, and she did just fine. Intraoperative occlusion of A2 ACA. So here's a patient previously coiled and very broad neck, maybe should have been stent coiled, or maybe it was a wrong case to coil anyway. So the patient was coiled and presents with now recurrent aneurysm. So we planned interhemispheric approach and clipping of this very broad neck aneurysm. But when the clips were placed, the problem is the coils were going into the vessel, so the distal ACA shut down. So here we have interhemispheric approach to the aneurysm. The optic nerve aneurysm is seen there. I have A1 left and the A1 right. So aneurysm is still pretty active. I'm taking a little bit of gyrus rectus from the superior side to get to the A1. So A1, that's the main, left A1 is the big one. The other one is small. But separating perforators from the aneurysm neck, and I'm putting the clip on where the neck is. Okay, that's the ACOM, separating vessels, etc. And now, I have to put an extra clip. Okay, so it looks good. Removing the temporary clip. Doppler, no flow in the left ACA. Now sometimes you can solve it by I'm adjusting the clip, but here the problem is some coils are going into the A2. So again, no flow. So basically at this point what I decided is that we need to do a distal bypass. So of course the approach anticipated this potential problem, and we are able to do the, basically I use an oval opening in the vessels, and we give heparin during the work, and then here we are suturing the artery, and so we have to suture the back wall from the inside. So first pass the stitch and tie it, and then what I would do is emerge, come inside with the needle, and then you suture from the inside because you can't flip this vessel. So you have to suture the back wall from the inside. Running suture. This is, I believe, 9/0 nylon. Most of the time is. So once you get to the other side, you can then emerge back, tighten all the loops, emerge back, and then you basically just suture the front wall and complete the anastomosis. So it's finished, and remove the clips and Doppler, and then of course you do ICG. It shows good flow now in all the vessels, and this patient did just fine. So unexpected occlusion. So I think I'll stop here because there's a lot more cases like this I can show you. But I'm trying to give you a flavor of different complications during aneurysm surgery. This one maybe I'll mention briefly. combined endovascular microsurgery treatment. So look at this very large and very broad neck aneurysm and a huge clot. So what to do here? So we actually look at this. So what I did was I said to my colleague, put a few coils near the apex. He said, this is not one that's going to be coilable. I said, put a few coils near the dome, and then I'll take out the clot today. So we just did that. We, look, a few coils, not coiled by any means. And then we went back and removed the clot, and this is, I had to go back and I was able to clip the aneurysm eventually. But this patient, however, needed a bypass because the clips were actually narrowing the aneurysm, the artery quite a bit. So she needed a bypass, and then she recovered. And this was a difficult case. This talks about small arteries. Where are these small arteries that can give you problems? We rarely operate on basilar tips anymore, but most of the time the problems relate to anterocoroidal, lenticulostriate, or Huebner's artery. These are the vessels that create the anterocoroidal, particularly, is very difficult for both microsurgery and endovascular surgery. They both people may wish that the other one it'll pass off to the other person, and sometimes the monitoring is very, very important to make sure that you have preserved this vessel, but it's not completely reliable. You know, there are cases where MEPs are totally okay, but then the patient, had a problem, and this patient, I looked at it and I'd say, okay, hey, the choroidal is still not, we have to reclip this one. You have to preserve the choroidal. So this was one of those cases. The ICG, see, there's a choroidal. But, and you think it's pretty far away, however, the clip was on it. Clip was kinking, because the aneurysm is a very broad, multilobular aneurysm. A different approach to this on the other side. So we're just following it back, make sure that the choroidal is intact. And it's okay, but it's a little delayed flow there. So we had to go back and I had to readjust the clip and put some papaverin, make sure that, the choroidal was all right. So the choroidal is one that you have to pay a lot of attention to. So that's the end. So microsurgery of aneurysms is not for the meek. Meaning you have to be prepared for complications. Most of the time you can manage them, but be prepared for those complications. Thank you very much.
Professor, that aneurysm, ACOM aneurysm which you showed, where you did a bypass.
Yeah.
Normally for ACOM, so you prefer interhemispheric approach or you do TVonal?
Only because the neck was very wide. Most of the time ACOMs I do operate by a Transylvian approach with a little orbitotomy or something and take down. But I think if the neck is very broad, or in that patient I knew that there was going to be a problem because the coils, it looks like it's going into the A2. So I anticipated there could be some problems with flow, distal. See, the problem is with the subfrontal or transcervine approach with the removal of the gyrus rectus. If there is a problem, you can't do anything. Sometimes I've had to. There was a problem, then I went back in hemispheric, did a bypass. So, yeah, it's a matter of in that case, I anticipated the issue. So, right.
The other thing is that you showed that the vessel bled.
Yeah.
I see it. You can suture that.
Yeah.
So is it because many times it happens? We may be operating somewhere, but there may be a small vessel.
Yeah.
It's because of high heat, the thermal energy of the microscope, and we drain all the CSF. The vessel becomes so brittle. So when our micro instruments pass that vessel, sometimes that can give.
That's possible. That's definitely possible. Also, dryness. It gets dried, or the patient may have some atherosclerotic changes. So something like that can easily happen. Also, you have retraction, so you're stretching something. So all of these things are possible. I just wanted to show that just be prepared to do something more. You can't leave the OR. Bottom line is you can't leave until the thing is fixed. And being able to put some sutures. Rarely you have to do a bypass. You think like you've done something, and then you find out later on that there's a stenosis, and so you have to do the bypass, either a good STMCA bypass or a high flow bypass secondarily. But of course, during the surgery, at least if you can put a couple of stitches, is helpful. So,
I have 3 questions.
Yes, sir.
One is about awake craniotomy and clipping. And second is about pre-coiled.
Yeah.
You showed a couple of venues, and we are also starting to see a few, because however good the center is, the regrowth rate is going to be there. And the third one is when there is a highly atherosclerotic vessel, which is where you have to achieve proximal control. How do you choose where to have those?
Good points. So awake craniotomy and clipping, popularized by Dr. Abdul Rauf, I don't like it. The reason is, it's just one more factor you cannot control. What's the ideal patient? There is no ideal patient, because the person you think is the ideal patient during surgery, we know from awake surgery for tumors, where we're doing awake surgery, glioma surgery and everything, the patient looks like an ideal patient, but then they are not able to control anything, so the anesthesiologist has to take them down anyway. So I just don't like it. The corollary to that is the awake coiling. So Dr. Elad Levy and Buffalo Group, they do a lot of awake coiling procedures. In our center, we don't like it. They clearly are doing it. And the problem is, again, the patient has to be absolutely still, and they're only doing it for unruptured aneurysms, I may say. But still, the issue is, if the patient just moves a little bit, the microcatheter jumps out. We have so many cases where everything is perfect. During coiling, the microcatheter jumps out, and the patient has a rupture, intraoperative rupture. So I don't like the idea of awake surgery. I don't think there is any benefit to that. Most of the time, unruptured aneurysm patients, we can get the patient home within 3 days, sometimes even 2 days. Only thing depends on how much pain do they have, really. So I don't see an advantage to that. So that's one thing, my personal opinion. The second thing was about previously coiled. We have quite a few patients with those things. It's actually, you have to be more cautious, because a lot of the time, of course, always the coils are outside the aneurysm, they've gone through. But more concerning is that the coils have herniated toward the neck of the aneurysm, not just the neck, but the parent vessel. So you put the clip, and then the clip is occluding the parent vessel. So you sort of need to be aware of that. And in some cases, you should be just prepared preemptively to do a bypass. The bigger problem is with ACOMs. Because ACOM, You think that it's the, what's the alternative? You have to A3 bypass or something. Or you can think about putting a stent and pushing the coils out. That's another option. But we are seeing quite a few of these people. It looks like everything is cured, especially MCA aneurysm. We see a lot of those. It looks like everything is perfectly cured. The patient is gone, and they come back with a rebleed. Now that you see that the aneurysm has grown, and something has happened. See, because in the patient's mind, that aneurysm is gone. So they don't follow up. In the doctor's mind, you got 1,000 other patients to take care of. You're not following the patient either. So you see these people that are coming back, So who's to blame? Nobody. You just say, okay, this is what we have with this disease. The last one was about atherosclerotic. Yeah. I prefer to avoid temporary clipping, especially for a longer period of time if the vessel is a lot of atherosclerotic change. Of course, during ruptured aneurysms, very hard to avoid. But unruptured aneurysms, if you can just bring the blood pressure down, I try to put a quick temporary clip on the, or temporary or permanent clip, what I call a tentative clip on the neck, rather than putting a temporary clip, if it's possible. Yeah. Yes, sir.
See, the azygos A2, it's a
Yep.
It's a special consideration.
Yes.
Many times everything goes well, even the distal azygos A2 bifurcation, and it has a stormy post-operative period. Do you have any specific precautions, or how do you deal with it? How to avoid that? Because everything goes well.
Yeah. Azygos A2, the main thing is that you need to know that it's prone to develop complications, and I think that that's one instance where you may really think about interhemispheric approach. Why? Because you see everything so much better. What you don't have with the interhemispheric, first of all, it takes more time. Secondly, you may not have good proximal control. But on the other hand, the distal vessels, you see them so much better than any other situation. So if especially the aneurysm is pointing back or something, I prefer that. That's one of the indications, in my opinion, for interhemispheric approach. Yeah.
Sir, good evening, sir.
Yes.
So, regarding the vasospasm following the ruptured aneurysm clipping.
Yeah.
So what is the current treatment guidelines, sir?
So mostly
if it
we're
is not responding to our routine nimodipine infusion or
by hypertension, they are not okay. So generally we start with milrinone, intraoperative milrinone, not intraoperative endovascular milrinone, and angioplasty will be done if it's possible. Of course, the angioplasty is also not without risk because you can rupture the vessel, especially A1. Is a more higher risk, more prone for rupture. Milrinone is very good. The only problem with milrinone is that you have to sometimes repeat it like 3-4 times. It lasts for about 24 hours. So, but it seems to be a good solution for the ACOMs in particular. MCA, of course, you could do angioplasty more. But occasionally we have ruptures even there.
Sir, is there any use of using cistern and lavage with nimodipine post-operative?
Yes. There is, there are some studies now with lumbar drainage just prophylactically. It reduces the vasospasm. We actually have a paper. We are actually going to launch a study where we are using TPA given through ventriculostomy, but it has a very small dose, and then lumbar drainage to eliminate the blood clot. But we have to do a randomized study. We did a preliminary study, it seemed to help, but we have to do a randomized trial in that case.
Thank
you.
What are the incidents of now clipping in US?
Clipping? Yeah. I would say in most centers, meaning places where more than 100 aneurysms are treated, 30 to 40% are clipped. I'm talking about ruptured aneurysm, not unruptured. 30 to 40% are clipped. In our place, it's almost 50-50. But if you were in a place like Buffalo, they have a very strong predilection for endovascular. But even there, they're probably clipping about 10 or 15% of the cases. Of course, when you have patients which go to places where they're doing a few cases, and they are all treated endovascularly. So like patients, center where there is only 10 or 15 patients. I mean, the people are doing endovascular quite. I mean, I have some colleagues, they do it, and if they have some problem, they send it to me afterwards. So, there's nothing you can do. It becomes a matter of judgment in their opinion, what is right and what's not right, And of course, we're also now, although not for so much for ruptured aneurysms, unruptured, we're seeing the intraoperative aneurysmal devices, just being deployed, contour and such different things. But again, many of them are treated incompletely, So what to do with those things? How are you going to follow them? So now with the unruptured aneurysms, a lot of the paraclinoid and proximal aneurysms are treated, most of them, not all, most of them by endovascular pipeline stent, so on. And if the more regular distal aneurysms, still there's a reasonable amount of clipping taking place. Yeah.
What is the incidence of the high flow bypass after the flow diversion?
After the flow diversion, I have a few cases. I didn't show them here, but unfortunately, some of them, the flow diversion complicates the patient so much that even high flow bypass doesn't solve the issue. Sometimes we have used them in combination, high flow bypass and then flow diversion. That also works. But the flow diverter actually makes the further treatments much more difficult. Sometimes clipping actually becomes easier because the stent is inside, you could put a clip on,
We had one recently, we had a growing aneurysm from the MCA.
Yeah.
Flow diverted twice in Germany and coiled partially and then regrowing, and actually it was easier to clip post flow diversion.
Close by, yeah, you guys, that was holding the artery open. Yeah.
Your percentage is cumulative, right? 30 to 40%, coil versus how much is it?
Change?
Circulation versus
Posterior circulation, majority are being treated by endovascular method.
So now the next question is, like, as a result, sometimes they keep on repeatedly coiling, especially based on different
Right.
tend to grow big.
Yeah, yeah.
Large mass sitting over there.
Right.
How do you tend to handle it? One, either because of mass effect or
Well, those become very difficult cases. We can do bypass, and terminal occlusion, or if they can be treated by flow diversion, that's always a nice thing, of course. But the more times they're coiled, then the more complex it becomes for anybody, and I have a few of those cases, of course. But it becomes more and more complicated patient, and higher risk for both the endovascular treatment and surgical treatment, So.
now your flipping confirmation earlier, you used to be doing microvascular and abdomen Doppler with endoscope. Now you're completely replaced with ICG or?
I do Doppler, use Doppler. Endoscopy sometimes.
Or because you're talking in terms of circulation slowing and
No, I use Doppler and then I use ICG angiography. Endoscope less and less, yeah. But sometimes, especially the ACOM aneurysms, it's very helpful. Also if posterior circulation, but then you have to get the machine inside and then look for it and so forth. That creates some problems sometimes. Yeah. Yes, sir.
A patient presenting with subarachnoid bleed, EBD done,
Yeah.
and cerebral angio presented showed ruptured aneurysm, posterior circulation, and incidental MCA, bifurcation aneurysm.
Yeah.
So endovascular procedure was done. Actually, ruptured aneurysm was coiled, but our endo preferred to coil the unruptured also. So what is your take on that, sir? Should we do that, or should we keep it for, once patient recovers?
Sure. So the question is, patient's present subarachnoid hemorrhage, there was like a basilar tip aneurysm that was coiled, but there's also an MCA aneurysm. What to do with that? I would say that if you feel that post-operatively that you will have to do induced hypertension for the sake of vasospasm treatment, the MCA aneurysm should be treated. However, most of the MCAs are better treated by microsurgery rather than endovascular method, So I would favor microsurgery rather than, but not favoring treating two aneurysms and two circulations at the same sitting, So that increases the risk to the patient. So you had catheter up and down in the vertebral basal artery and everything, and then now you've gone to, and you don't know how the patient is going to be doing, and now you go to the MCA aneurysm, put some coils. What if the patient wakes up with a hemiplegia? You don't know what happened to the patient. So I would favor two different stages. Maybe treat the posterior circulation aneurysm and then make a decision. You want to do microsurgery or endovascular or something. Yeah.
Thank you so much, sir. I think to be a complete neurosurgeon, you have to be a vascular surgeon as well. Otherwise, you're not going to be a neurosurgeon. So thank you so much for coming down, spending time with us. And may I request Professor Suresh Bapu, Dr. Raghavendra, Dr. Kodishwaran, and Dr. Chandrasekhar, please. Have Dr. Suresh Bapu giving a shawl to Dr. Professor Laligam Shekhar, please, sir. And we have Dr. Raghavendra and Dr. Kodishwaran handing over the gift to. Thank you so much, sir. Please join us for dinner.
I'm glad many people mentioned that.